Hey everybody, this is going to be part two. I kind of cut off part one abruptly, but figured everybody might need a break and kind of a stopping point. And the longer the videos get, the longer they take to upload. So going on to part two. I didn't go into a lot of pathophysiology of breast cancer because it's pretty straightforward. I find that prostate cancer is something that it's worth a little bit to talk about the physiology of androgens and that to make sure we understand for people um, how these drugs work and what we're trying to do. Okay. Remember that for prostate cancer, it's still a solid organ. And so the first choice is always going to be local treatment with surgery or radiation. For men with prostate cancer that's metastatic, their only options then become drug therapy or chemical quote unquote castration. Androgen androgen deprivation therapy, ADT, which always makes me think of the ADT security system ads, but ADT, androgen deprivation therapy is how it's always referred to, is the largest group of drugs that we have to treat prostate cancer. There are some now different immunotherapies that have come out. We can still use some cytotoxic therapy. And those kind of things. There's also a huge risk of metastatic bone involvement. So oftentimes people in prostate cancer need to have that treated with Zometa or denosumab or something like that. But for prostate cancer, I do think it's worth talking a little bit about androgens. So I'm going to back up there. Okay, remember that androgens come from the testes. For men, right? We're talking about men. 90% are produced in the testes. So androgens, the main one we're talking about is testosterone. However, our adrenal gland and the prostate itself and prostate cancer also secretes testosterone, about 10%. So most of the free testosterone that we have is going to be coming from the testes. But we have to remember that even if we were to remove the testes or only focus on the testes, there's still going to be other sources of testosterone. Okay. So we have three ways that we can reduce the influence of the androgens. So androgen deprivation therapy. We can block testosterone receptors. We can lower testosterone production, and we can lower testosterone production by castration. Drug therapy is more effective than castration because castration, again, only eliminates the testes, and we still have that other 10% that would be produced. But if we give drugs that block testosterone receptors and testosterone synthesis, then we're influencing testosterone from all sources. There are four different classes listed here of androgen deprivation therapy. So what we're trying to do, just like in breast cancer, is starve the prostate cancer from its fuel, quote unquote, of testosterone. So we have gonadotropin releasing hormone agonists. We have gonadotropin releasing hormone antagonists. And then we have androgen receptor blockers, and then the CYP17 inhibitors. All right, so talking a little bit first about the GnRH agonists. So these drugs suppress production of androgens by the testes, but not the adrenal or the prostate cells itself. Okay, this is the drug Lupron or Eligard. Leuprolide is in this class. Okay, so we use this for the prostate cancer. Leuprolide, or I'll say Eligard, is a synthetic analog of the gonadotropin releasing hormone, also known as a luteinizing hormone releasing hormone, which is LHRH. Okay, Leuprolide is indicated for advanced carcinoma of the prostate with palliative as your intent. For patients with prostate cancer, Leuprolide represents an alternative to orchiectomy, which is again the surgical castration and removal of the testes. So this is a drug castration. Cells of the prostate, both normal and cancer cells, are androgen dependent. So Leuprolide provides palliation by suppressing androgen production in the testes, which is great because that's where 90% comes from, During the initial phase of treatment, leuprolide mimics our natural GnRH. That is, the drug acts on the pituitary to stimulate release of the interstitial cell stimulating hormone, which acts on the testes to increase production of testosterone. So if you want to know how leuprolide works, we're actually working on the pituitary to stimulate the ICSH, to stimulate the testes to increase production of the testosterone. So as a transient flare can happen in prostate cancer symptoms, but with continued exposure to the leuprolide, the GnRH receptors in the pituitary become desensitized. So as a result, your ICSH, that interstitial cell stimulating hormone, declines, and that causes testosterone production to decline too. Important thing to remember is that when you initiate these drugs like Eligard and Lupron, people can have a flare of kind of intense symptoms. They can have the hot flashes, all of those kind of things. And then after several weeks, you'll see the decline in the prostate because you've desensitized the pituitary ICSH down to the testes cycle. So eventually the ICSH drops off and the testosterone stops being produced. Because this drug therapy then mimics the effects of orchiectomy, this is what's called chemical castration. So these are the gonado this leuprolide then is the gonadotropin releasing hormone agonist, okay, not the antagonist. So although leuprolide does not decrease production of androgens made by the adrenal glands or by the prostate cancer itself, the non-testicular sources are only about 10%. So even though it doesn't hit it all, it hits the majority of it. Some patients receiving leuprolide, an androgen receptor blocker, can help also. So you can have co-treatment with an androgen receptor blocker. Specifically, this can prevent cancer cells from undergoing increased stimulation during the initial phase of the GnRH therapy, when androgen production is actually increased. And it can block the effects of adrenal and prostatic androgens, whose production is not reduced by the agonist. So the current trend is to use an androgen receptor blocker during the first weeks of leuprolide therapy to prevent the leuprolide-induced tumor flare, and then the drug can be discontinued, but you continue the leuprolide. So leuprolide is generally well tolerated, but most people are going to get hot flashes. Over time, that seems to reduce. They also often have erectile dysfunction, loss of libido, gynecomastia, reduced muscle mass. They can have diabetes, an MI, and a stroke. So leuprolide is not without its possible bad side effects. The hard thing is that during your first initial weeks of getting this drug, you can actually aggravate and flare up the cells of the cancer. And so if they have metastatic bone cancer from this, they can have a lot of pain during those first couple of weeks. They can also get urinary obstruction from the prostate as well. So you have to find that or have to educate that, and sometimes they're really miserable with that. But now that we've messed with the hormones and we have now suppressed your testosterone production, you're now at increased risk for osteoporosis and related fractures. So they're always educated to make sure they have adequate calcium and vitamin D, that they're doing weight-bearing exercises, but often these patients, just like breast cancer, are also on bisphosphonate or denosumab. Okay. The next possibility in here is the triptorelin and the goserelin, and those things, they're essentially the same as leuprolide. So then we go into the next category is gonadotropin releasing hormone, GnRH, antagonists. So these drugs also suppress production of androgen by the testes. However, these antagonists do not produce the initial flare. The drug is called Degarelix or Firmagon. So it's a synthetic GnRH antagonist, only used for palliative intent in advanced prostate cancer for men who are not candidates for the agonist therapy and who do not want surgical castration. So again, you're still suppressing testosterone production by the testes. This mechanism works by reducing the GnRH receptors in the anterior pituitary, which then decreases release of the luteinizing hormone and the follicle-stimulating hormone, which then is what deprives the testes of the stimulus for the testosterone. But because it works through the direct blockade of GnRH receptors, it does not cause that initial surge, and so there's no tumor flare. So the agonist can flare the tumor, the antagonist does not. Same side effects essentially as the agonists. However, this drug can give you injection site reactions, weight gain, and elevated LFTs, and after a year of treatment, about 10% of patients will have developed an antibody against it and can't do it anymore. So the androgen receptor blockades that I've already kind of spoken of, we oftentimes refer to these as anti-androgens, right? And they're only indicated for advanced androgen-sensitive prostate cancer and only in combination with surgical castration or chemical castration with the agonists. Okay, so these are not drugs that are used alone. Currently, there's 3 on the market. Okay, flutamide is their prototype that they talk about first here. I am much more familiar with seeing bicalutamide or Casodex as the drug, so I'm going to focus on that. Here in Sioux Falls, that's what I've seen most used as well. So bicalutamide is Casodex, and that's an androgen receptor blocker used for advanced androgen-sensitive prostate cancer in men undergoing therapy with Lupron or Eligard. They have to be taking the GnRH agonist in order to really get the benefit of this drug. It is just as effective as flutamide and dosing is more convenient, which is why we see it more. Benefits derive from the blockade of the androgen receptors in the tumor cells, so you're depriving them of the needed androgenic support. So in patients taking the GnRH agonist, these, like bicalutamide, can serve 2 purposes. It can prevent the tumor flare, and it can block the effects of the adrenal and prostate androgens. They call this complete androgen blockade when you have both. It is reserved for suppressing the initial flare and suppressing the tumor after it has stopped responding to the GnRH agonist alone. So typically you get the GnRH agonist alone first, and then typically they'll add on bicalutamide. The combination is not used continuously because it does not increase survival, but it can increase toxicity levels. It can pose a significant risk for fetal harm, so you can't take it by pregnant women, and they have to be careful even with handling the pill. The other one they actually mentioned in your book, the nilutamide, I've never seen that in practice, and I can tell you why. It sounds like it's really not well tolerated. Okay, then this next class is the cytochrome P450 enzyme 17 inhibitor. Busy word. This is abiraterone, and this is used in combination with prednisone to treat metastatic castrate-resistant prostate cancer in men previously treated with docetaxel. So it's a very specific indication, meaning they've already received their dose of Taxol. The reason is that they're castrate-resistant. The cancer is not responding to castration therapies. So the benefits derive from inhibiting the production of testosterone by the adrenal gland and the prostate cancer itself. If castration has not been done, abiraterone can also inhibit the production from the testes. It inhibits the CYP17, which is an enzyme needed by the adrenals, testes, and the prostate in order to synthesize testosterone. So when tested in men with metastatic castrate-resistant prostate cancer, the combination of abiraterone plus prednisone increased overall survival by nearly 4 months and progression-free survival by 2 months. Okay, so we're not talking like these are life-shattering drugs. I know in one of the earlier parts of the lecture I had said that some of these metastatic cancers where people are living a long time with it, prostate cancer is not really one of them. Once it gets to be a metastatic prostate cancer, the survival is not very good. Okay, adverse effects of these drugs then could be hypokalemia, edema, joint swelling and discomfort, muscles, pains, hot flashes, as well as increased risk for UTI. They can have diarrhea, cough, and hypertension. Abiraterone can also decrease libido, muscle mass, bone mass, can cause erectile dysfunction and gynecomastia. The reason why the edema is a thing and why you have to take it with prednisone, which is a corticosteroid, the inhibition of the CYP17 in the adrenals can lead to overproduction of mineralocorticoids and underproduction of glucocorticoids. So you have to take it with prednisone. High levels of those mineralocorticoids are what can cause the retention of the sodium and loss of potassium, and you get the edema, hypertension, those issues with that. So low levels of the glucocorticoids can put you at risk of death, right? You have to have enough glucocorticoid. So they get it with prednisone. Other problem with abiraterone possibly is hepatotoxicity, so you do monitor their ALT, AST at baseline every 2 weeks for the first month of treatment and then every month thereafter. You should discontinue it if the liver enzymes go nuts. And this is also one that needs to be avoided by pregnant women. It can interact with some of the drugs, and one of the big ones is ketoconazole. And it can clarithromycin and then some of the seizure drugs. So you got to pay attention to that. The next drug they put on here is ketoconazole, right? Weird. Ketoconazole is a drug we use for our fungal infections. However, it can be used off-label for prostate cancer. So as with abiraterone, the benefits derive from inhibiting testicular, adrenal, and prostatic production of the androgens. Ketoconazole is employed as a secondary therapy in men who continue to have a rising PSA despite treatment with the GnRH agonist and the androgen receptor blocker or the anti-androgen. Doses are higher than those that we use for antifungal, so common effects are a lot more severe or more pronounced. Nausea, vomiting, fatigue, skin changes, liver changes, and gynecomastia. Also, because high-dose ketoconazole can suppress adrenal production of the glucocorticoids, it's usually given with hydrocortisone to avoid adrenal insufficiency. So yes, you may meet somebody who's taking ketoconazole for prostate cancer. Then they have the category of others, which is really kind of cool that this is up and coming. So this is Sipuleucel. It's really cool. You're taking your body's own immune cells that's made from each patient and then giving it back to the patient. It's very expensive and only moderately effective, but it's of great interest, and it kind of is showing us that we're having some of those newer immunotherapy options. I do want to point out here just quickly, the majority of prostate cancers are adenocarcinomas, like by far and away the large majority. However, there's also prostate cancers that can be small cell, organ, and neuroendocrine cancers, and those are a little bit different. So there is a small subset of different types of prostate cancers. So that's important to remember as well. So those treatment therapies for those types of prostate cancers are not necessarily what we're talking about here. That's a whole different ball of wax, and it's treated differently. And those kind of prostate cancers are bad. They have a dismal prognosis. There is some newer treatments out there since the publication of this book. One of them is a drug called Jevtana, which is cabazitaxel. So it's a Taxol therapy, and it's meant to be taken after you still are having metastatic prostate cancer after you've had docetaxel. And I find this interesting because this drug works by inhibiting cell division, leading to death, right? So Jevtana binds to the tubulin inside the prostate cancer cell, and it promotes its assembly into microtubules while simultaneously inhibiting disassembly. So it breaks it down while also preventing the cancer from fixing itself. This leads to stabilization of the microtubules and results in the inhibition of the mitotic cellular function, right? So that cell cycle is really cool. This is what I'm talking about. They continue to make really neat, higher, just cool drugs that are coming out. So this is indicated to be used in combination with prednisone for treatments for patients who have metastatic castrate-resistant prostate cancer, and they've already done docetaxel. So that one's a new and interesting thing coming up. Another really cool thing that's popped up in the last couple of years is PSMA targeted therapy. And what happens is the PSMA stands for prostate-specific membrane antigen targeted therapy. So it uses radioactive tracer to target and destroy the PSMA, which is a protein on the outside of the prostate cancer cell. It's called Pluvicto because it's the PSMA therapy with the specific radio tracer. So the PSMA is a protein and an antigen. So the antigens are substances, remember, that we can have our immune system respond to. So prostate cancer cells make the PSMA and they put the antigen on the surface of the prostate. And so now we have this very specific targeted therapy, better guided radiation therapy than general prostate guided radiation therapy. So it's really cool. Most people have already undergone chemo or hormone therapy or chemical castration. You need to have an MRI, and then you get a PSMA PET scan, and it uses the radio tracer to find and attach. Okay, it gives that way to the PSMA scans, which are then visible on your scan. And those kind of works together. It's really cool. So then what happens is that the PSMA therapy takes that dose directly to your prostate cancer tumors so that the radiation will have minimal effects on the other parts of your body, which is really good because prostate cancer radiation can really lead to like hemorrhagic cystitis down the line and scarring and decreased erectile function and all sorts of things. So this PSMA targeted therapy, it's really cool. It's not technically a drug that you're given a radio tracer, but again, it's following along with what we're talking about, that we have a lot of more targeted therapies available to us. But really, the majority of what you're going to see is the androgen deprivation therapy, like we've talked about up here, and a lot of those, require really good education for the patient of the symptoms that you're probably going to see. Remember that the abiraterone needs to be given with the prednisone. So if you don't know why the heck the patient's on the prednisone and then you're like, oh, they're on the abiraterone, they have to take it together. You don't just want to stop their prednisone. And I can tell you there's a lot of people that don't understand why they're taking the prednisone. They're like, they just told me to take it. And I've seen people come into the hospital and then they stop that because they're like, well, you shouldn't be on a prednisone for no reason, not realizing that it's given together for that. All right. So again, the cytotoxic drugs are typically docetaxel and cabazitaxel, which we already talked about. Then estramustine is a hybrid molecule composed of estradiol, which is an estrogen, coupled to the nitrogen mustard, which is the alkylating agent. And so there's a small indication for that for advanced prostate cancer, which is really interesting and kind of cool. Then we have the targeted anti-cancer therapies. So these are drugs that are designed to bind with specific molecules, right, the targets, with the goal of suppressing tumor growth. The hope is that these drugs will be more selective than the hormones or any cytotoxic drugs that we have, and hopefully we'll be able to destroy cancer cells without leaving the normal cells untouched. Okay. One of the big drugs in this is another NIB, and that is Gleevec, which is imatinib. And this has been very, very successful in the past with very little bad effects. So that was kind of like a prototype, and we took it off. We went from that. So that's a NIB. Targeted drugs, what I want you to understand, are antibodies that bind with specific antigens on tumor cells. Others are small molecules that inhibit intracellular enzymes. So some of the antibodies mark the cancer cells for that immune attack. Some block the cell surface receptors, and then some deliver toxic drugs or radioactivity. Some prevent blood growth to the tumor, preventing their blood supply, and they die off. So there's a multitude of different ways that these drugs can work, but these are the ones we called the targeted anti-cancer drugs. So the first, if you're on table 85.7 in your book, the kinase inhibitors, which is the EGFR tyrosine kinase inhibitors, cetuximab, panitumumab, gefitinib, erlotinib, these ones. And so some of these are like colorectal, head and neck, lung cancers, etc. What I want you to recognize is just that these are targeted drug therapy. I want you to recognize that it's a NIB or a MAB. So these are those targeted immunomodulators that we've been talking about, and that you're going to see. So like one that you may see a lot of is someone may be on Tarceva, which is erlotinib for a non-small cell lung cancer. And you have to kind of worry about maybe some of the major toxicities with that. One of which is GI perforation. So, you got to be careful there, or that they can develop interstitial lung disease. So if you have someone who's been receiving Tarceva and they show up to your ER, your walk-in clinic, and they're short of breath, those kind of things, just to be familiar with them, kind of scroll through there. The next one are the BCR-ABL tyrosine kinase inhibitors, and that's where this imatinib was, dasatinib, nilotinib. These are very common drugs that we see in the leukemias, especially the chronic leukemias, and they've been around for a long time and they work pretty well. The two that I would point out is like dasatinib and nilotinib could have QT prolongation, and then the multi-tyrosine kinase inhibitors, there's in there sunitinib for renal cell carcinoma is a very common one. I don't want you to worry about remembering all of these. Just have this chart available if you needed it to answer a question. There's just too many to even possibly try to remember. The other one, everolimus, which is under the mTOR kinase inhibitors. It's a drug called Afinitor. It's very common in renal cell carcinoma, but this one really does have some problems with metabolic abnormalities or oral ulceration. So if you ever encounter a patient and you do your diligence and you're going to be a great provider and prescriber and you are going to get the world's best in-depth medication record, right, a med reconciliation, and you're going to ask them and you're going to find out that they're on everolimus, then if you go to a chart like this, you would know, oh, I need to be looking for bone marrow suppression, metabolic abnormalities, right? So I don't expect you guys to remember them. But you will maybe hear them called by these names. So like the like the BRAF drugs or the BCR-ABL drugs or those things, you may hear them referred to as that. And that's what they're talking about, is there a specifics kind of kinase inhibitor. Okay, finally we get to CD20 directed antibodies. Okay, and I want to talk about this very quickly as well because it's really important to understand this one. Rituximab is in here. Rituximab is used for a large variety of reasons. It's a pretty common drug. People are on it for autoimmune disorders. People are on it for cancers, a multitude of different things. It's probably one of the most commonly given MABs out there. Okay, it binds to the CD20 antigen, causing apoptosis and an immune attack. So it's an antibody, but it can have the potential for severe infusion reactions. People can take it and do just fine, and some people don't. These are the drugs that you have to give, or afatinib also. They are given in an infusion center or in an ER or someplace because you have to monitor for serious infusion reactions. And I bring this up because people could be on rituximab and maybe you're about to give them their 8th dose and they're always like, I tolerate it fine. I'm like, no worries, I'm going to go shopping after this. That doesn't mean that they couldn't potentially have their infusion reaction. Okay, the next one to point out as well is the angiogenesis inhibitor. So bevacizumab is what it's called, and it's known as Avastin. In the acute care world, this is one that's very commonly used still, especially in some glioblastoma, renal cell, and colorectal cancers. But if someone's on bevacizumab, the trouble with it is they can have impaired wound healing, hemorrhage, nephrotic syndrome, thromboembolism, and GI perforation. But it's the impaired wound healing that's a kicker. If someone is on bevacizumab, which is Avastin, and they come in with a trauma, they've broken their ankle, they've done whatever, you are in a pickle. Because specifically how this drug works is it inhibits angiogenesis, which is the creation of blood vessels. It's effective when you're talking about tumor, but if now you need rapid wound healing and proliferate, all those things, now you're on a drug that prevents the ability to kind of make new blood vessels, and it is a booger sometimes for it. The other problem with bevacizumab and Avastin is that if people need dental work, you have to be off of this drug for like 30 days or something because you are not going to heal and you could have some serious bleeding problems. And so when I say bleeding, I mean hemorrhage. I mean that if someone's on bevacizumab and you go and you get a tooth pulled, whoever dies of a tooth being pulled, someone on bevacizumab, like you could bleed out from it. So it's a big deal in the cancer world too. And I would point that out to people as well. The list just keeps on going. There's so many things to talk about. I'm pointing out some of the ones that I think you're going to see a lot in practice. Sorry. The book then goes into talking about the kinase inhibitors and what they mean, and that there's these different types of kinase inhibitors. So the first one we already talked about is the EGFR kinase inhibitor and what those look like. It's still a monoclonal antibody, that is the kinase inhibitors that are working differently throughout the body, and we've already talked about that in enough detail. What I wanted to point out in these drugs, again, there's a lot of them, but I want you to go down and look at the one, afatinib, which is Gilotrif. But afatinib is an example of a drug that is now a nib, right? So it's immunomodulator. But it's really cool because it's one of the ones that show us this is a very targeted drug. So when your tumors are sent off for pharmacogenetics, when you say I'm waiting on the genetics, you're waiting on to see, and you send it off for that genetic testing because you're looking for certain genetic codes, like afatinib then. If we know that this tumor in your lung has an EGFR deletion, then this drug is going to be great for you, right? So these are the kind of things that make cancer so exciting now, is like having lung cancer, horrible. But then you find out that your tumor is EGFR deletion, and it's very sensitive then to afatinib, and all of a sudden you're taking maybe an oral pill every day that's such a specific targeted therapy. You tolerate the side effects much better. So it's such a better treatment and quality of life than someone who's like, oh, I don't have a targeted therapy to offer you. I just have to give you cytotoxic treatment. So, I mean, afatinib can have its complications, don't get me wrong. It can cause really bad diarrhea. I mean, it's still a thing, but it is exciting for people to know that we have options sometimes to really target your therapy. Okay. I mean, it's really neat. The drugs that are needed for CML, I'm kind of going through pretty quickly. The one that's kind of interesting is ponatinib, which is one that's for adults with CML that's resistant to prior therapy, but also for those with a Philadelphia chromosome positive type of gene. So again, that's another one that's really neat. I do not expect you to be able to go through all of these and memorize them all, anything like that. There's just too much here. But you can, as you scroll through and you read these, then you can become a little more familiar, like you've seen the name and what we're doing here. Going down in your chapter then to rituximab specifically, it works by the CD20 antigen, which is found on the surface of most normal and malignant B cells, and it causes cell lysis. The adverse effects can be severe infusion-related hypersensitivity, right? Big deal. You have to worry about that because they can get sudden, severe hypotension, bronchospasm, and angioedema. So you have to discontinue the infusion. You're rapidly given epinephrine. Okay. The other thing you have to worry about is tumor lysis syndrome, which is because you have rapid and massive death of tumor cells, and they kind of clog the system, quote unquote, and cause some renal impairment, and that could also be fatal. You also can get some of the severe mucocutaneous reactions, including the possibility for Stevens-Johnson syndrome, lichenoid dermatitis, toxic epidermal necrolysis, and death could even occur from those. The other one is that giving rituximab have been reported to leading to hepatitis B reactivation, which is also problematic, because that is the situation that hepatitis B reactivation can lead to fulminant liver failure. So rituximab is out there, it's used a lot, but it has the potential for really bad side effects. And so you have to pay attention to that. It is pretty common in my anecdotal experience to have people receive rituximab and get the flu-like syndrome with it during this. Like afterwards or during, they feel feverish, nauseated, kind of the chills. You kind of feel like you have a mild flu. And so I've just wanted to point that out because that is a true possibility of something that you could see. So the next thing I want to go down to hitting on is, let's go down in your book down to immunostimulants. So immunostimulants enhance the body's immune attack on cancer cells, which is awesome. And this is where you find like interferon or PEG interferon, okay? And these are drugs that are often used in melanoma, some other cancers as well. But interferon alpha 2b, interferons are naturally occurring proteins with complex antiviral, anti-cancer, and immunomodulatory actions. So the release of our own endogenous interferons is triggered by viral infections, etc. Interferons are active against a variety of solid tumors and hematologic malignancies. But we have two forms of interferons. There's interferon alpha 2b and then PEG interferon alpha 2b. The PEG interferon is simply a long-acting form of the interferon alpha, which adds a polymer to it and extends the longevity of its action. The polyethylene glycol PEG is attached to a native interferon alpha 2b. Okay, so although the active components of the interferon alpha 2b and the PEG interferon are the same, these preparations have different indications, so I wanted to point that out to you. Interferon alpha 2b is approved for melanoma, leukemias, some lymphomas, and some AIDS-related Kaposi sarcoma, whereas the PEG interferon alpha 2b is only for melanoma. These drugs work by two basic processes. One, they enhance our host immune response, and two, direct anti-proliferative effects on cancer cells. And both processes are mediated by binding the interferon alpha 2b to the cell surface receptors, and they work that way. Interferon alpha 2b can cause the G0 cells to remain dormant, preventing proliferation. So that's really neat. However, it's a drug that can have multiple side effects. It can have that flu-like syndrome, and then can have some of your other varied ones, but also can have cardiotoxicity, neuropsychiatric effects, especially depression are associated with that. So I wanted to point that out because that is a drug that is still used quite a bit, that you will see in different things. The next one, if you go down, the other weird thing is this thing called Bacillus Calmette-Guerin vaccine, which is a BCG vaccine. And you may see this as BCG treatment, and it's approved for primary or relapsed carcinoma of the bladder, and helps treat bladder cancer. It's administered intravesically, which is directly into the bladder through your urinary catheter. So that's pretty cool. It also can be given to protect against TB, but I see that in practice still sometimes as well. So I wanted you to hear there's this vaccine that we can use for bladder cancer. And then towards the bottom of the chapter here, it starts talking about glucocorticoids and when we can use them with patients with cancer. These are typically higher doses because glucocorticoids in these high doses are directly toxic to lymphoid tissue. So high dose therapy can help in things like Hodgkin's, multiple myeloma, or lymphocytic leukemias. And then, of course, there's the role of the glucocorticoids, like we've already talked about with the nausea and vomiting, the dexamethasone for reduction of cerebral edema, etc. Then the next drug they talk about a little bit is retinoids, which we already talked about, which is vitamin A, that bind to and activate retinoid receptors. So this can be helpful because the retinoid receptors regulate the proliferation and differentiation of cells. So in patients with cancers, the retinoids can actually inhibit cell growth. So there's a couple of those out there that I would just want you to be aware of, that they're from the retinoid family. They do have the potential for their own serious adverse effect of a retinoic acid APL syndrome, which is something that's interesting on that as well. The next drug I'm going to point out that they talk about in this chapter is thalidomide. It is still around. Back in the day, everybody got thalidomide in the 70s, and we found out that it caused severe birth defects because it was teratogenic. So now in the United States, it's only used for erythema nodosum leprosum, so leprosy, and multiple myeloma. So just throwing it out there, it still is in existence and can be used. But if you think of thalidomide, you're going to hear all the bad things about thalidomide, but it is a very powerful teratogen, very powerful. So it's very, very strictly monitored. But lenalidomide is an offshoot of that called Revlimid. And so we have a much safer version to give. We do use some of the progestins as treatments for endometrial cancer and even renal cancer. That's in here as well. Sorry, I didn't flip the screen. My bad. I'm moving right through and didn't flip your screen. So sorry. Okay, then we talk about cancer immunotherapy and chemoprevention. Chemoprevention is often thought of to be as cancer treatment, and it's not. These chemopreventions aren't typically used to treat cancer. They are used to prevent cancer or lower your risk for getting cancer. We have vaccines for that, like the HPV vaccines, which was Gardasil, to help decrease the risk for cervical, anal, and throat cancers by HPV. We have hepatitis B vaccines to prevent hepatic cancers. And now we have some cancer immunotherapies. So I did want to go through this with you. It's an interesting branch of cancer treatments. You're going to hear about it, but I'm not worried too much about you guys like memorizing anything, but I want you to hear it and be familiar with it. So what we're talking about is the idea that immunotherapy, we want to augment our body's own ability and our own natural defense to attack cancer cells like it would a bacteria or a virus. And so they're really working on that, on how to do that. The problem has been is how do you overcome the inability of our T cells to recognize cancer cells as foreign cells, right? Cancer cells are smart and they know how to evade detection. So like we said, they don't respond to our normal checkpoints or our normal regulation things we have in place to signal cell death. They just blow right past it. They don't respond. So this paragraphs in here talks about the cancer checkpoints. So genetic changes can result in a decreased expression of the tumor antigen. Cancer cells also carry checkpoint proteins that allow them to go undetected amongst healthy cells. So some of these proteins have been identified, right? So we've gotten smart and we figured it out. And these are, you'll hear this terminology, PD-1 and PD-L1 or CTLA-4. So scientists discovered that they could use monoclonal antibodies as checkpoint inhibitors to attach to these proteins on the cancer cells. Subsequently, the T cells were able to recognize that they're cancer and annihilate them. So this is really cool because this is what they call antibody-dependent cell-mediated cytotoxicity. It's been very, very, very successful for melanoma. And so these checkpoint inhibitors, PD-L1 or PD-1 inhibitors, are things like pembrolizumab, nivolumab, avelumab, ipilimumab. They're very cool. They do have the possibility of some adverse effects, but they work really well. It's really crazy. So checkpoint inhibitors, that's where that idea comes from. Then we have adoptive cell theory, or it's also called adoptive immunotherapy. So we have chimeric antigen receptor therapy, which is CAR T cells. So you'll hear of like a CAR T. T cells are removed from the patient's bloodstream and genetically modified to express this chimeric antigen receptor. The CAR is a T cell receptor protein that allows T cells to effectively recognize, attach to, and destroy the cancer cells. So this type of immunotherapy can be really effective in some of those leukemia. So you'll hear it called CAR T cell therapy. So that's really cool. That's out there. Then we already talked a little bit about the vaccines. Were the only other ones that we're talking on there. Okay, so this was a really long lecture. We talked about so much. Really go off of, in preparation for your test, the things that I talked about with you today. Don't get so caught up. If I didn't focus on it in this lecture, please don't focus on it in your reading in terms of preparation for your exam. This is what I'm talking about when I say that there's so much content in pharmacology and advanced pharmacotherapeutics that it can become really tricky to hit everything out in practice. You know, we live in a digital age, which is wonderful, which we'd have to do because we have so many drugs. There's just so much knowledge that there's really no way we're always going to know everything. So the idea is that we kind of have an understanding of it and we know to go to our resources. As always, please let me know if you have any questions or concerns. Thanks, guys.